Hi, I'm John Martin. I'm a private practice OBGYN from Las Vegas, Nevada. This next video will be on what to do when you have a miscarriage. Doctor. And of course, these options should be discussed with your physician. There's really three options you have with a miscarriage. Number one is wait to see if your body will spontaneously miscarry the pregnancy. For me personally, I like to do that in patients that are early on in the pregnancy, so it's not as traumatic with the amount of bleeding and the pain they might have. It's really always up to you and your physician as to whether you do that. A couple common misconceptions about waiting for the spontaneous miscarriage is that it is harmful to you to have that lost pregnancy inside of you. Once the baby is passed, people worry that is there risk of infection or something like that. The truth is there is very little chance of infection. That is a sterile environment inside the uterus. So you could wait 1 week, you could wait 6 weeks to have a spontaneous miscarriage. Now, I don't advocate, and I'll explain to you my personal thoughts on this, waiting as long as 6 weeks. But it is safe. It's not putting you at risk for any danger. For me, the biggest thing is you know you've lost your baby and you have this insult of still feeling nauseous, feeling breast tenderness, and yet you know that it's to no avail because you're not going to have a baby. So that's the hardest part, that emotional part of having those feelings of pregnancy and knowing you're not going to get a baby out of it. The second option is to take a medication called Cytotec or misoprostol. I've personally used it for over 20 years. It's used in very low doses to stimulate labor in some women, but in high doses, it can help expedite a natural miscarriage. So it'd still be the natural miscarriage or the waiting and the spontaneous abortion. And if you're unclear about that terminology, I have a video on terminology of miscarriage. But it's still a spontaneous miscarriage, but the medicine helps induce it. Now, this is a medicine that's designed for ulcers, but in high doses, it works as a prostaglandin that stimulates your uterus to contract. Now, it's not to be confused with the morning after pill, which actually works completely different. It prevents you from implanting a pregnancy, or the abortion pill, which is RU486, which actually physicians have to have a special license to prescribe that, and that is to abort a normal pregnancy. This is a pill that is designed to facilitate a spontaneous miscarriage. Again, it's called misoprostol or Cytotec, and the dose we give is very high, but it is not dangerous. It does cause some abdominal discomfort and cramping because it is a medicine that works on your intestines and the gastrointestinal system, but it's not harmful to you. So that is the second way of trying to induce a spontaneous miscarriage, but it is separate because you're using the medication. The last method of ending a miscarriage is to do a traditional, what is called a D&C. And the term is dilatation and curettage. Dilatation is opening up the cervix so we can get inside with instruments to remove the tissue. And curettage is the actual scraping of the lining of uterus to remove the tissue. Now, this is usually done under anesthesia or heavy sedation. It is a painful procedure and it's an emotionally difficult procedure. So I would not recommend that you go to a doctor who doesn't sedate you or put you under anesthesia to have a D&C. That is my own personal opinion, but I think it's very difficult to go through that and it is painful. There's some little things they can do to help you with pain, and that would be a discussion with your doctor. But I do feel like you need some kind of sedation or anesthesia. The traditional D&C is the quickest way to end the miscarriage. You can be scheduled once that miscarriage is confirmed and you've had that pregnancy loss or that abortion, which means that there's no chance that this can go on to be a normal pregnancy. Then you discuss with the doctor doing the D&C. There is risk to it. There's really three main risks. Anytime you have a surgical procedure, there's risk of infection. So you're going from the outside world to inside the uterus, which the outside is a non-sterile environment and the inside is a sterile environment. So that can potentially cause an infection, and that should be discussed. The second is bleeding. You actually bleed more with a D&C than you do with a natural miscarriage. For those of you who've gone through natural miscarriages, you'll find that hard to believe because the blood loss is scary. But what happens with a natural miscarriage, your body's blood vessels kind of contract down and it compensates and it decreases the blood loss. On a D&C, we're going and taking that tissue out and the body's not ready for it. So we sometimes give medicine to help the uterus contract down and bleed less. So there is more bleeding at the time of a D&C. The third thing is an injury to the uterus, which could potentially interfere with future pregnancies. You can have something called a uterine perforation, where a hole is poked in the uterus, and that needs to be repaired. There are even cases of severe injuries where women may need emergency hysterectomies or even such severe injuries and blood loss that you can pass away from these complications. Very rare. I always say in my personal experience, I've done over 1,000 D&Cs in my career and never had any of those severe complications. The other complication that can interfere with your fertility is something called developing syncytiae. Syncytiae is a fancy word for scar tissue, and it's scar tissue that develops within the uterine cavity, and it prevents the uterus from forming normal lining of the uterus, or what's called endometrium, and that can interfere with your periods. It can interfere with you being able to achieve pregnancy. Again, a very rare complication. I always counsel patients on those risks: the injury to the uterus being the perforation of the syncytiae, the bleeding, and also the infection, but they are very rare. So my own personal thoughts: when I was a young physician, I used to believe that it was better to naturally miscarry because the less blood loss, no need for anesthesia or instrumentation, all of those things. But I actually changed my viewpoint because I realized how hard it is emotionally to go through a pregnancy loss and then sit and wait for the natural miscarriage. And that is a very difficult thing because, like I said before, you get all the messages of pregnancy, but yet you're not going to get a baby out of it. So for me, what I have done with a lot of my patients is we'll kind of reach a happy medium. I'll say, look, if you haven't naturally miscarried, or we try this Cytotec / misoprostol, and you haven't miscarried by a week from now or 2 weeks from now, then let's get you scheduled for a D&C. So we have an endpoint for how long we'll go on with that. That's just my personal viewpoint. You can always talk to your doctor about what they'd like to do. The people who advocate natural miscarriage are not wrong, whether it's naturally your body doing it or using the Cytotec or misoprostol. It's hard to predict when it will happen. Unfortunately, you can spot or bleed for days or even weeks before you'll have a miscarriage. And then there are people who advocated D&C, and I think the reasons they advocated are those things I talked about. Let's just get it over with and let's move on. And sometimes that is really the best way to go. I hope this video was educational and helpful. If it was, please follow me on Instagram and Facebook, like it, share it with your friends. Thank you very much for your time. Be safe, be kind, and be well, and have a great day.
Doctor, doctor.